All right. So where we left off last class is we were talking about increased ICP, and just make sure you go over the page 124 to understand why increased ICP can be fatal. And basically just understanding, and you can even write this down, that increased ICP can be fatal because it will reduce blood flow to the brain tissue. Okay. The more swelling there is, the more it compresses the arteries of the brain, and that's going to cause brain cell death. And as that progresses and gets worse, the more brain cell death there is, the more swelling there is, which makes the problem worse. Okay. I also want to make sure that on page 122, where it says care of the conscious client or the unconscious client, that you read that table. It has very good information on important nursing interventions. Now, I kind of summarized those important nursing interventions on the next page, but let's just briefly go through the high points that will really help you on questions for your exit and your NCLEX. So when you're caring for an unconscious client, your number one priority is airway, okay? So make sure you write this down. When someone is unconscious, they cannot protect their airway. So like you and me right now, like I'm awake, and if somebody was to like stick something down my throat, I would gag, I would cough, right? So that's my body's way of protecting my airway. But I'm awake, I'm conscious, I can do that. But if I was to be either sedated or unconscious, I would not be able to protect my airway the same. And so definitely someone who's unconscious, they can't gag or cough. And so that is why airway is the number one priority. You want to monitor blood pressure, pulse, and heart sounds, and respiratory and circulatory status. So that's your B and C, your breathing and your circulation. So right away, you see the essential priorities of nursing: airway, breathing, and you will get breathing by your respiratory status, which would be your respiratory rate, your oxygen saturation, your lung sounds, and then your circulation, which is your heart rate and your blood pressure, and also your O2 saturation. If the client is unstable, don't leave them alone, and that's for any patient. So any question you get and the patient is unstable, whether it's unstable vital signs or unstable respiratory status, you do not leave them alone. You can call for help to come to you, but you don't leave the patient. Make sure you understand that you want to maintain a patent airway for someone who's unconscious, because CO2 is a vasodilator. So for those of you who were with me last class, we wrote that down. CO2 is a vasodilator. And then so increased CO2 would make increased ICP worse. So I know that this is a review for most of you. Some of you are new, but it's just to make sure you remember that CO2 is going to open up the blood vessels. So if someone has increased ICP, CO2 would cause more blood to get to the brain, and it would make the swelling worse. Okay. Always assess for lung sounds. So the unconscious client, they can't protect their airway. They can't cough. They can't get up and walk. So them laying in bed is going to increase the risk for pneumonia and a buildup of secretions and atelectasis. So we want to listen to their lung sounds so that if they start to have rhonchi or diminished lung sounds, that we can suction them as needed. Okay. Um, Most of the time, 9 times out of 10, when we're talking about a neuro patient that is unconscious, they're probably intubated. And so write this down. Intubation increases the risk for pneumonia. significantly, significantly. So when you're talking about an unconscious patient, your number one priority is always airway because they cannot protect their airway. So that is why when we're talking about an ICU patient that's unconscious, 9 times out of 10, they are intubated. Okay. And so once a patient is intubated, we have secured their airway. And we'll learn about that in Module 6, respiratory. Second priority is breathing because when someone is intubated, they're going to be on mechanical ventilation the machine will breathe for them or provide the air and the pressure so that air can come in and they can have oxygen enter the bloodstream, and it will provide the negative pressure so they can exhale and CO2 can leave. So once we're caring about somebody who's unconscious and who has increased ICP or is at risk for it, we really want to monitor the ventilator, the mechanical ventilator, because we don't want CO2 to build up in the person's body. That would make the ICP worse. So we want to make sure we monitor that. Assess neurological status. You want to assess level of consciousness by doing the Glasgow Coma Scale, and we talked about that last class. Also, pupillary reactions. Um, you want the client in semi-Fowler, so make sure you write that. And that's also in the book. You can highlight it. So here where it says interventions for increased ICP, keep head of the bed 30 to 40 degrees. So semi-Fowler. So please write that and highlight that. For the unconscious client, you want them in semi-Fowlers so that they can expand their chest and they can breathe properly. Okay, you don't want them laying flat. Remember, they can't protect their airway. They might aspirate and choke on their oral secretions. Okay, you want to change their position every 2 hours. Remember, somebody who's unconscious, they cannot move themselves, and so they're at great risk for pressure ulcers. We want to avoid Trendelenburg position. So remember, Trendelenburg position is head down, feet up. We want to avoid that because that's going to make ICP worse. That's going to increase their ICP. All right. Use side rails unless it's contraindicated because we don't want them to fall off the bed. Okay. Assess for edema because remember, this patient has a whole special set of needs. And them laying in positions like laying in the same position, it can lead to dependent edema and things like that. Monitor for dehydration. Can someone tell me how would you monitor a patient for dehydration? What are some things that you would check? Let me make sure that everyone can unmute themselves.
Urine output.
Does
Scan,
the skin to go?
scan, the
Beautiful.
scan, urine output.
Sugar, mucous membranes.
Oh my gosh, very good. And what are two other really quick ways that's part of the vital sign? Which vital sign tells you about fluid volume status?
Blood
Blood
pressure.
pressure.
That's very good. So one of the first signs of dehydration that might be apparent, besides like, let's say they're unconscious, they're probably going to have a urinary catheter. Because if they're unconscious, they're going to be in ICU. And so in ICU and really in nursing, there's subjective and then there's objective. So if there's a way that we can turn something into like an objective number, we should do it. So if they have a brief on, like a diaper on, and they pee 2 times, it's really hard to figure out like, well, how much did they pee? Did they pee enough? Versus if they have the urinary catheter, you can measure their urine output and then you can divide it by how many hours it took them to pee that so that you could get the hourly urine output. And then you have something to base it on because you're like, okay, a normal urine output is what? What's the normal range?
30 ml per hour.
Very good. So 30 mLs per hour is the lower limit. So we don't want our patient's urine output to drop below 30 mLs an hour. And the higher limit is 50. So 30 to 50 milliliters per hour of urine is how much the healthy, normal adult should produce. So the whole reason I said that is when you're taking care of an ICU patient and you walk in the room, technically the first thing you can see just right quick, besides looking at the patient, is the urinary drainage bag hanging on the edge of the bed. And you could kind of start to see like, oh my gosh, that's really concentrated urine. It's very dark, dark gold. And it's not enough. But also the quickest, easiest way is to check their blood pressure and their heart rate. So if somebody's dehydrated, what is their blood pressure and heart rate going to look like? So dehydration, is the blood pressure going to be up or down?
It's gonna be up.
For dehydration.
Down. It will be down and heart rate is gonna be up.
Very good, very good. The blood pressure is a representation of the fluid volume status of the body. So when fluid volume is low, like dehydration, fluid volume is low, the blood pressure is low. When there's too much fluid volume, the blood pressure is high. So and because with dehydration, the blood pressure is low, the heart tries to compensate and the heart rate increases. So the blood pressure is low, the heart rate is high. So ways to monitor for dehydration, check the heart rate, check the blood pressure, check skin turgor, check urine output. Okay, so those are some ways that you can check. And then when we get to peds, we'll learn about the different set, like, well, the fontanelles and things like that. So you want to monitor their intake and output in their daily weight. So remember, this is not someone who can sit up and eat a meal. They're unconscious. So everything that comes in and out, it's your job to monitor it just to make sure that, of course, they're getting enough in and that what we're putting in somehow comes out, right? So if they're getting normal saline 75 milliliters an hour and they've been getting that for 12 hours and they haven't peed, is that a problem?
Yes.
Yeah,
Yes, it is.
because
Yes, it is.
yeah, everything in nursing, it's like if you put something in, something's got to come out, right? There has to be some result. So if they're getting IV fluids around the clock and they're not peeing, they're at risk for fluid volume overload. And then that's when you might start to see the edema and things like that. So also you want to monitor the output, making sure that they're peeing 30 to 50 mLs an hour. Also, making sure that they're having normal stools and it's not just diarrhea, because then that could mean that they got C. diff and you will want to put them on enteric precautions and alert the healthcare provider. Also, you want to monitor their daily weight. Um, they might have an NG tube and be on like, the feeding tube, like the kangaroo pump. Um, in worse or, more complicated situations, they might be on TPN. So just monitoring their weight and communicating with the doctor and the nutritionist to make sure that the patient is getting the right nutrition based on their situation. You know, maybe if it's like an unconscious client because of their like a burn patient, just making sure maybe that they're going to need extra protein in their tube feed, so whatever needs are there for your patient, you have to monitor it every day and every 4 hours, every hour. It depends on what it is. So maintain nutrition as prescribed. Again, it can be IV like TPN, or it can be enteral feedings like an NG tube feeding. Monitor fluid and electrolyte balance. So again, fluid balance, that's your blood pressure, your urine output, your skin turgor. The electrolyte balance, that's monitoring their labs every morning or evening, depending on your shift. When consciousness returns, check the gag and swallow reflex before resuming a diet. Assess bowel sounds, monitor elimination patterns. And so that's just to make sure, because when they're unconscious, we still just want to make sure that their bowels are functioning and that they're having normal bowel movements, so that if they're not, you can let the healthcare provider know. So monitor for constipation, impaction, and paralytic ileus. So again, the first signs is to monitor their bowel sounds and see if they're pooping. And if they're not, maybe the healthcare provider can order a stool softener. Okay. Because again, when they do regain consciousness, we don't want them straining. So that was also on page 123. No straining, because it would increase ICP. So if they're not pooping or having trouble pooping, stool softener. Once they wake up, if they're still constipated, stool softeners, more fiber, more water, more liquid intake. Um, Maintain urinary output to prevent stasis, infection, and calculus formation. So, when they're unconscious, they can't drink water, they can't drink, they're not awake. So they're going to get IV fluids and also the fluids in the TPN if that's what they're getting. So you just want to make sure they're peeing enough, because if they're not, that little bit of dehydrated pee they'll have in their bladder, it'll stay there and cause a UTI and sepsis and make their situation worse. And also, it can increase the risk of kidney stones, which would be really painful and would complicate things. Monitor the status of skin integrity. So again, your role in that is making sure you're turning them every 2 hours and that you're doing a full skin assessment at least once a shift as a nurse. And so if they are at risk, if they have like an area of redness, or if they have a stage 1 already, pressure ulcer, now you're going to have to like turn them more diligently and put them maybe on an air mattress, um, and then consult like the wound care nurse and make sure they're getting enough protein in their diet so that their tissues can rebuild. So it's a lot of responsibilities. And this is just one patient. And this is just, I know these are different assessments, but these are things that you're going to have to do constantly for this patient. Um, Provide frequent mouth care. So remember, they're at risk for pneumonia. And so that nasty bacteria in our mouth would love the opportunity to get into their airway and cause pneumonia. Remove dentures and contact lenses. Obviously, we don't want any kind of blockage of the airway with the dentures, and we don't want the contact lenses to like roll in the back of their eyes. Um, or we don't want any damage while the contact lens is on the eye. Assess the eyes for the presence of corneal reflex and irritation. So that basically is their blink reflex. So your cornea is a transparent covering over your eye. So let me show you a picture, because I know in nursing school, I could just not get this. In nursing school, I didn't understand what the cornea was for anything. I tried to memorize it, but until you see these pictures will help you understand better. So when we're talking about corneal reflex, we're talking about the cornea. The cornea is like a transparent outer covering that, protects the eye. So this picture can also kind of help you to see. So a normal cornea, you shouldn't really even see it, but it is just a transparent covering. It's the first contact that your eye has with the outside world. And then this person has a condition of their cornea that it's misshapen. So I show this picture because it's in someone with keratoconus. their cornea becomes deformed. So that helps me to show the students, wow, the cornea really is on the outside of the eye. So, assess the eyes for the presence of the cornea reflex. So you can do that by opening the eye and just kind of moving your finger towards the eye to see if they would blink. And also just making sure that if they are, unconscious and don't keep their eyes closed, we can tape their eyes closed because we just don't want their corneas getting scratched and irritated and dry because if your eyes stay open all the time, dust and things are going to get in and your eyes will get dry. Eyes were definitely meant to stay moist. That's why we have eyelids and stuff like that. So we can put artificial tears and drops. We can use eye patches. Monitor for drainage from the ears or nose for the presence of cerebrospinal fluid. Remember, we learned about halo sign. um, Assume that the unconscious client can hear. So, I mean, when I was doing clinicals for nursing school and I got the privilege to do clinicals in the ICU, oh my gosh, like I seen some nurses, or yeah, I've seen and heard some nurses say some pretty messed up things like right in front of the patient. And I'll never forget we were in ICU and this patient was doing horrible, like respiratory wise, just really going down in the toilet with it. And they decided to intubate him. So I was assisting with the intubation as a nursing student. They let me like pull up the medication and hand it to the doctor and everything. And then after I gave the doctor the medication, I think I went to hold the patient's hand. I don't remember exactly, but I went to hold the patient's hand and the nurse was like, "Oh, I didn't even think he was going to make it this far. I didn't think he was going to last this long." And like just saying all this negative stuff. And I'm thinking at this point, because we gave him a powerful sedative, I thought the patient was sleeping. But the nurse is just going on saying, like, yeah, basically, like she thought he was going to die a long time ago. She can't believe he's still alive. And then as I'm holding the patient's hand, I look and his eyes are open. We gave him a powerful medication. I look and his eyes are still open and he squeezes my hand. So he heard everything she was saying, even though he had got this powerful, powerful sedative. So be careful what you say. And speak life over your patients because you could be, you know, the last thing between them dying or living just with your words and your actions.
Somebody can be healthy and you die before somebody that's really sick.
Right, right. So I'll never forget that. And I was like, man, and like you'll never be the best nurse you can be until you're a patient. When you are a patient or you take care of someone like full time, a caregiver or something, you will really understand what it means when somebody needs a nurse because you once needed a nurse. And I remember when I had to have my gallbladder taken out that in the pre-op holding, I had to sign paperwork. And well, I had signed the paperwork. I mean, they were telling me about the surgery, and it's just like, so they're like, yeah, so the surgery is going to be in about 10 minutes. And so, the anesthesiologist came and told me what they were going to do and put me to sleep. The surgeon came and talked to me. And then the nurse came to talk to me just to answer any last minute questions. And I remember thinking like, okay, so they're about to put me to sleep. I might never wake up again. And these are all strangers. Like I don't know any of these people, and they literally are about to have my life in their hands. And that situation, I feel helped me to be like a better nurse, an even better nurse, like more compassionate, understanding. Um, The next tip is to avoid restraints unless it's absolutely, absolutely needed, because again, they're just so much at risk for skin breakdown. Um, Initiate seizure precautions if necessary, provide range of motion exercises to prevent contractures, and use a footboard or high top sneakers to prevent foot drop. So let me show you a quick picture of foot drop. So this would be a wedge to help to prevent foot drop, but let me show you something. So foot drop is kind of like how this foot is, where it's like they've had no support to their feet for so long that the feet, like these the joints here kind of lose their elasticity and just like the foot drops forward. And it can be permanent. So they can use devices like this to help to prevent that. All right. So very important things. These are things that the NCLEX and your exit are going to expect you to know. So make sure you take your time. On page 123, go over how we discussed the nursing interventions for increased ICP, monitor respiratory rate, no morphine. So when a patient has increased ICP or they are unconscious, we avoid morphine because it leads to respiratory depression and can it lead to hypoxia. Maintain mechanical ventilation, making sure you remember that CO2 is a vasodilator. So write this down. If you didn't write it down last week, you want to slightly hyperventilate the patient with increased ICP. You want to slightly hyperventilate the patient. And so you will work with the doctor in respiratory therapy for that. So hyperventilation, you're going to remove more CO2 from their body because remember, CO2 is a vasodilator that would make ICP worse. So here are some things that you can do to further prevent increased ICP. We want to prevent shivering. We want to decrease environmental stimuli, no straining, coughing, sneezing, bending, or Valsalva maneuver. Keep the head of the bed at semi-Fowlers. Okay. All right. Um, Page 125, hyperthermia. This is a temperature higher than 105 degrees. And this could lead to death, okay? Because this is outside of the normal temperature range that our body is accustomed to living with. So this is incompatible with life, this degree or this temperature. So some causes could be infection, heat stroke, or dysfunction of the thermoregulatory center in the hypothalamus. Interventions protect the airway, especially because the higher the temperatures is, the more likely it because it increases the brain metabolism. The higher the temperature is, so it's going to increase the excitability of the neurons in the brain, and it could lead to seizures. Okay. So whenever a patient is at risk for seizures, the number one priority is airway. Okay. So airway, seizure precaution, intakes and output to make sure they're getting enough fluids in, because fluids, especially if they are able to drink, or even just IV fluids, would help to reduce the body temperature. Fluids, cold baths, fans, um, okay, a hypothermia blanket, which would help to reduce the body temperature. Traumatic brain injury. Traumatic brain injury is a head injury causing trauma to the skull, resulting in mild to extensive damage to the brain. So there are different types of head injuries. You have concussions, contusions, hematomas, and fractures. So concussion, and I know this example is a little bit dramatic and a little bit uncomfortable to say, but it's the clearest example of how I can think to describe a concussion. So if your brain was a marble and your skull was a glass jar, a concussion would be that the marble hit the glass jar and then, okay, so just imagine your brain hitting, like something jerked the body so much that the brain kind of hit the skull from the inside, and that caused the person to pass out. That's a concussion. A contusion is a bruise. So someone can have a concussion, which is the jerking movement causing the brain to accelerate and hit the skull, and the resulting damage. It could be a contusion, which is a bruise, or it could be a hematoma where there's blood forming, like blood pooling, or fractures of the skull that also lead to brain injury. So complications, hematomas. So let me show you a picture of hematomas or a hematoma. Okay, this one.
Miss Alexander, I have a question. Is that the same thing as bleeding under the skin?
Yeah, so very good. Yeah, so if someone has a hematoma, like you can have a hematoma anywhere on your body, but if it's in the brain, they're more likely going to identify the hematoma, like name the hematoma by the location of where it is. Um, for example, they usually use the meninges as reference points. So, like, let's say this is a subdural hematoma. So, location wise, where would you say that this hematoma is located?
Under the skull.
Under the skull. And is it above or underneath the dura mater?
Above it.
Under the
Oh.
dura mater.
Under, right? So,
Yes.
yeah, it's under because it says subdural, right?
Mhm.
Yes.
Because the common ones is like subdural hematoma or subarachnoid hematoma.
Mhm.
So subdural hematoma, so as you can see, it's a collection, a pooling of blood. So this is going to increase ICP because this is taking, the blood begins to take up space where the brain should be. And that increased ICP is going to compress, it's going to press on the arteries of the brain, and the area where those arteries are supposed to perfuse will become ischemic and then eventually will die because it's not getting enough oxygen. And if that person has enough, a large area of brain death, the person will either automatically die or the brain will herniate. Okay. So you can see this is part of the skull here, and you don't see the whole thing, but this is part of the skull. Where the brainstem exits the skull is through the largest hole in your skeletal system called the foramen magnum. Okay, the foramen magnum. And so what can happen is when increased ICP gets so bad, because remember we said the brain is really trapped in the skull. It's trapped. The skull is not gonna like expand, right? So if there's something taking up space where the brain should be, or if the brain is swelling so much and pressing up against the skull, that can't, it's not permanent. It's if we don't fix that problem, it probably will lead to death because eventually, when the brain just has nowhere else to go, it's going to herniate, where a portion of the brain is going to exit through the foramen magnum. And the problem is the medulla oblongata and the pons is here in the brainstem, or a little bit up here in the brainstem, and that's what controls breathing. So if this subdural hematoma gets large enough, that the brain has no choice but to evacuate the cranium. The brain is going to slide down and herniate, and the area that controls the breathing, the medulla oblongata and the pons, is going to press against the foramen magnum, and then the person won't breathe, and then they'll die. So these are the consequences of, traumatic brain injury. Okay. So complications, hematoma, and we just understood why that's dangerous. And that leads to things like uncontrolled increasing ICP and brain herniation. Also, traumatic brain injury could lead to infections because, the chances of, especially like if it's like a skull fracture, um, now the brain is vulnerable to infection, and the meninges too, which could lead to meningitis, seizures. Seizures is your brain's way of saying I'm very hyper excited and I'm irritated. And so any of these things can lead to hyper excitability and irritation. Assessment, so definitely assessment of traumatic brain injury probably will affect their level of consciousness. It could lead to coma, changes in behavior, cranial nerve deficits. Okay. And that's going to depend on what area of the brain is affected. Okay. So I'm going to, let's go ahead and take a 5-minute break. I'm going to pull up a slide so I can show you some pictures, and we're going to keep talking about this. Thank you so much. All right, guys. So I have a question. What would you do? You are at a community football game and you are a nurse, and you observe that one of the students runs into another player. The player falls onto the floor and is unconscious. You go to help the player. What should you do first?
I'll first of all try to see if the airway is open and make sure the patient is not crowded.
Okay, so airway. Okay, very good. What else? So how would you check the airway? Like, would you would you just like look at it? Would you touch it? Like, are you gonna look for the outcome of having an open airway? So what is the outcome of having an open airway? What should the person be able to do?
Other than breathing,
Breathing, very good. So
Breathing.
yeah, so the outcome of having an open airway is the person can breathe, right? Because assessing airway is so weird because it's like, how do you assess the trachea? It's like, you know, deep in there. But yeah, so we really assess, like, you can assess the appearance of the airway because you can have well, if the patient's looking up, you want to make sure it's midline. You also listen so that there's no weird noises when they breathe. But the quickest way to assess the airway is to assess the outcome of it being open, which is they should be able to breathe and not have any weird sounds. So, so are you saying the first thing you do is to check if they're breathing?
yes.
Okay, I like that because you're knocking out two birds with one stone. You're assessing airway and the breathing part. Because if they're breathing, they have an open airway. What's the second thing you check?
Consciousness.
Mm,
Hmm.
So
If other than checking for breathing and the airway, I'm going to see if there's any physical injury, maybe like bleeding.
Yes, fracture.
because they're
Yeah,
unconscious, right? So
yeah.
they're at the bare. We have to do a bare. We have to hit like the basics first before we move up. And
Vital
there's
sign. Vital
So I'll
sign.
be assessing for bleeding or
right.
any injury,
So
physical
someone can,
injury.
okay, vital signs. Bleeding is gonna come, so very good. Vital signs, right? Because remember, what does the word vital mean?
Blood pressure,
Critical.
respiration.
Right. But what is the word vital? If I say this is vital to your
Like very critical.
Important,
The
Very
important.
important.
all the
yeah,
important stuff.
very good. So the vital signs, it's like it's gotta be there for that person to be
Mhm.
alive, right? So when we're in these situations, where we like the chances of you going to a football game and having a blood pressure cuff and a thermometer are very low. But at this point, we have to just hit the ABCs. So we hit airway and breathing by checking if they're breathing, because if they're breathing, they have an open airway. So that's A and B. So what's left?
Circulation.
Circulation. So how do we check circulation?
Feel the pulses.
Beautiful, beautiful. And also if we had a blood pressure cuff, that would be great. But so is it safe to say that in this situation, the first thing you need to do is assess, correct?
Yes.
Right. Because as a
Can you
nurse,
check the fingernails
yeah,
No, I
for
don't.
circulation or no?
well, I mean, technically, yes, checking their fingernails or their capillary refill is part of circulation.
Yeah,
However,
we'll do capillary refill.
however, like they were just running. They were just awake and running. That would be more like if you found them or whatever, but still, that wouldn't even still be. Um, Breathing and pulse would be the first things that you would check. Um, and so you would assess because remember, as a nurse, When you don't know what to do, you have to assess. You're going to base your next action off of your assessment. To assess means to gather information. And as a nurse, you always want to make a move you want to make an appropriate move based on what the information is telling you. So that if you go kneel beside him and he's not breathing and he doesn't have a pulse, you can tell someone to call 911 and you're going to begin CPR, right?
Mm-hmm.
But if you kneel beside him and he is breathing and he does have a pulse, but then his mom yells out, he's a diabetic, and brings you the blood sugar machine and you check his blood sugar and it's 64, right? That
Mm-hmm.
assessment took you another direction, right?
Hypoglycemia. Mm-hmm.
Exactly. And then if the mom's like, here, he has sugar tablets, and you put one to dissolve under his tongue or on his gums or something, you know what I'm saying? So it's like when you don't know what to do as a nurse, you assess. So that's why for the exit and for the NCLEX, when it's like, oh, which of the following interventions should the nurse perform next or first, or which of the following is the priority? Usually, 9 times out of 10, the answer is assess something, check the blood sugar, check the blood pressure, get blood to check a level of something, you know. So you would assess, and you're gonna assess if he's breathing and he has a pulse. Okay, those are the two major assessments because if he has those things, he can stay alive long enough for help to get there. If he doesn't have those things, what should you do? And we just said it.
Start
Yeah.
CPR.
Start CPR.
That's the CPR.
But before you even start CPR, what should you tell someone to do?
Call 911.
Call 911.
Because remember, once you start CPR, you can't stop, right?
Mm-hmm.
Right.
So once you start, if no help's coming, you're gonna be there. You can't stop. And if no one else at that football game knows how to do CPR, you're gonna be there all night till he comes back to life or something. So you want to know that help is on the way. So you gotta check if he's breathing, if he has a pulse, and then if he has those things, you can quickly inspect him because remember, if he's breathing and he has a pulse, you're like, okay, I don't need to do CPR. What's next? If you don't know what to do next, assess. So you quickly inspect him, right? And so he is breathing and he does have a pulse. You're inspecting and you note that there's clear drainage coming from his ear. So what do you think has happened? What do you think that clear drainage is that's coming?
Probably brain injury.
Cerebral.
Uh-huh. What is that clear fluid probably? What do you think it is?
That's the spinal fluid.
Yes, that is cerebrospinal fluid. So what you have to do is understand that there's a possibility for head trauma. So you have to understand whenever there is a possibility for head, neck, or spinal trauma, you have to treat the patient like they do have it. So I want you to understand the difference between possibility and they do have it. So possibility means like, oh, I just saw him run into someone. It knocked him out. He might have hit his head really hard. He might have twisted his neck, something. He might really have hurt his spinal cord or something. Possibility and then verified, right? I want you to know you have to treat them both like they have it until you know they don't. Do you see what I'm saying?
Yes.
So if there's a possibility that someone has had head trauma, you have to treat them like they have head trauma until you have the diagnostic imaging that confirms they don't have it. Because what you don't want to do is you don't want to paralyze someone by causing an incomplete injury to now become a complete injury. He could have hurt his spine really bad. Because what surrounds the spine? What surrounds the spinal cord? Let's look at this.
The bones, little bones.
And what are those bones called? What are those bones?
T3, T1, T4.
The vertebrae, right? So when someone gets injured, can bones break?
Yes.
Oh yeah.
And when bones
Yes.
break, can they break into sharp pieces?
Yes.
And can those sharp pieces maybe sever the spinal cord?
Yes.
And so that's what I'm saying. Like, he can have a really bad injury that's a partial injury, and we can accidentally turn it into a complete injury if we don't handle this patient correctly. Okay. So when someone has suspected head injury, you are going to move them very delicately. Okay. And you're going to do that by using the following principles. You want to immobilize the neck. So you don't want him like bending his neck forward or back or side to side. You want his neck to stay straight. You want his neck to be aligned with the body in a neutral position. Okay. So don't let anyone put something under his head. Don't let anyone pick him up and, oh my gosh, wake up, baby, wake up. You're going to say, ma'am, there's a chance he might have hurt his neck. It's best that we keep him straight. Okay. So no head flexion, rotation, or extension. So what is neck flexion or head flexion? What's that? Are you bending the head forward or backward? What's head flex?
No.
Hmm?
Flexion, I think it's backward.
Mm-mm.
You said you cannot immobilize.
Yeah, when you move the head forward or side to
Yeah,
side,
Forward, very
flexion is moving it because of
moving
the
it.
delicate. Yeah, so you don't move it.
Very good. Yes, you don't want to move it outside. You want it to stay straight, neutral. So head flexion is if the person were to like touch their chin to their chest, right? So bending the
Mhm.
head forward, you don't want them to do that. And you can remember flexion means to move towards the center of the body in a way. Okay, so flex, right? And then so that
Yeah,
means
yeah, mama.
extension is like putting the head back, like trying to look at the ceiling, right? So, like, extension is to put the head back, and then hyperextension would be asking them to look at the ceiling, and then rotation side to side. So, no head flexion, no rotation, no extension. Their head has to stay straight. So, if you do have to move the patient, you can log roll them. So, you can see this is a team effort, okay, where each person is responsible for one segment of the body, and you move the person in alignment together. You're going to say 1, 2, 3. So you have one nurse at the head holding it so that to make sure the head and the neck stay aligned. You have someone at the upper chest, the abdomen, and the lower legs, and then the lower legs. So and you're going to say on the count of 3, we're going to roll him this way, 1, 2, 3, and then someone else, like a fifth person, can slide the gurney under him, okay, or the transfer board, and then you're going to say, okay, on 3, we're going to lay him gently down on the gurney. 1, 2, 3, and you all lay him as one unit down. So this is how we have stabilized the patients. And then we're going to put a C collar on them. Has anybody ever heard of a C collar? Okay.
Some kind of traction
Mhm.
to
So
see that the head is not, the neck is not moving sideways.
beautiful. Perfect. Yes. So we've all seen these before, right?
Yes, I have.
Yeah.
Yes.
You ever see like when somebody gets into a car accident or something, the next day they're wearing this, right?
Mhm, mhm.
So a
Mm-hmm.
collar, what do you think the C stands for?
Cervical.
Cervical, beautiful, because those are the cervical vertebrae that it is keeping in alignment. So can this person in the collar, can they look down?
No,
No.
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 It prevents head flexion. Would it
but sometimes they will,
Remind ya.
can you put a cream there? Can you, it kind of itchy,
be right?
it's,
Right. Right. But in the brain, in the head trauma patient or the potential head trauma patient from the football game question that we're working on, um, excuse me, I'm trying to find that. In this patient, when the ambulance got there, they would probably put this on him. And it's just a way to keep his neck in alignment. It prevents head flexion
so
and
that can heal
exactly. Well, so that
slowly.
stay straight. Yeah. So it could stay straight. And then when they get him to the hospital, they will probably do like a head CT and an X-ray just to assess for traumatic brain injury, for injury to the spinal cord and things like that. Okay. So, of this case study that we were doing, there was something that really bizarre happened. Clear drainage started to come out of this guy's ear. And we're thinking, hey, is this CSF? So I want you to know that there's two ways that you can test drainage to see if it is CSF. So if head, neck, or spinal trauma is suspected, do not clean the ears or nose if there's drainage present. So if anyone has suspected head trauma and they got clear stuff coming out their nose or ears, don't wipe it away. Don't. You know what I'm saying? You want to test it. So you can do halo test. You can also test for glucose. So
It can be some kind of content coming from somewhere that is not coming from CSF.
well, if it's coming from the nose, it could just be like really clear mucus, but that's why you're going to test it to see if it's mucus or CSF. And then from the ear, I don't know of any clear fluid that's going to come from the ear that's not CSF. But um so we'll talk about the glucose one first. So if you want to check if there's drainage coming out of someone's ear or nose and you think they have head injury, you can dip a glucose test strip in it. And now if it has glucose in it, it is likely CSF. Okay, because mucus wouldn't have glucose in it. Okay. The next one is halo test. So halo test, you have to apply a dry sterile gauze to the ear or the nose, and you are going to look and see if it makes this pattern. Okay. So it's going to have blood in the center and a halo or ring of CSF around it. Okay. So as you can see on the pillow, this gentleman unfortunately has halo test or the halo sign, excuse me. You see that? Okay. All right, guys. So let's do a couple of questions and then we're going to talk about what your homework is for the remainder of the week. One moment. All right, so question 92. Which of the following is a priority during the first 24 hours of hospitalization for a comatose client with suspected drug overdose? Please tell me what the answer is. Hello, can you guys unmute yourself?
We cannot see.
We cannot see the
We
question.
cannot see the question.
It just there's not a page on top of it.
Oh, okay. What about now?
Yes.
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 Which of the following is a priority during the first 24 hours of hospitalization for a comatose client with suspected drug overdose?
Induce regarding drug abuse.
Minimize,
Minimize pain.
no.
Did I hide it again?
Yeah.
Yes.
Yes.
Hold on. What about now?
Yeah, it's good now.
Okay.
Uh-oh, some part of it is cut off.
Miss Alexandra, can you make the question full screen?
Okay, it's
It's
good
good.
now.
Yeah,
There you go. Thank you.
You're welcome.
There you go.
One.
He's comatose.
no.
Comatose. Very good. So we're still gonna treat him like he can hear, right? But that this what's the key word in this question?
Priority.
Priority.
Priority. This is a tough question.
Yeah, 4.
During the first 24 hours?
Minimize pain.
Two. Minimize pain.
Group 2.
And maintain intact skin.
Yes, because did it say anything about pain? Or any
I think number 2 answer is the 3.
correct answer is number 3. Very good. Um, Very good. So let's read this question again. So which of the following is a priority during the first 24 hours of hospitalization for a comatose client with suspected drug overdose? So the key word here is priority. So you're focusing on what's more important right now, and then also it's the first 24 hours. So you can't educate a comatose client, okay? So for you to educate someone, they have to be awake and not in pain and not anxious. Um, okay. For the minimized pain, nothing in what he's got going on indicates possible pain. And the increased caloric intake is the first 24 hours. So of course, if need be, they will insert an NG tube um, to provide him with nutrition, and then the nutritionist and the healthcare provider would work to see if they need to increase the caloric intake. But in the first 24 hours, yes, we're going to try to find a way to give him nourishment, but the priority would be to maintain intact skin because he's unconscious and immobile, and the risk for pressure ulcers and pneumonia or stasis pneumonia from not moving is high. So interning him every 2 hours, we're helping to prevent skin breakdown. And also in a way, helping to prevent stasis pneumonia. Number 93, an unconscious intubated client does not have increased intracranial pressure. Which nursing intervention would be essential? Okay. Monitoring the oral temperature, keep the room at 70 degrees Fahrenheit, and place the client on a cooling blanket if the client's temperature is higher than 101. Clean the mouth carefully, applying a thin coat of petroleum jelly and moving the endotracheal tube to the opposite side daily. Positioning the client in a supine position with the head to the side and slightly elevated on two pillows. Turning the client with a draw sheet and placing a pillow behind the back and one between the legs.
Positioning. 3.
I'll do number 4.
Mhm.
No, turning the client with draw sheet.
3.
2.
Do you want to put the patient, the unconscious patient supine?
No.
Because if you put them supine, what could happen?
They can chew,
Aspirate.
aspirate. Okay.
Exactly, they could aspirate, right? And
Mhm.
they're already intubated. And what did we say? When a client is intubated, what does that increase their risk of?
Choking.
ICP.
I
Of
see.
pneumonia,
Pneumonia.
right?
Aspiration increases with pneumonia.
Right? And then isn't there a type of pneumonia called aspiration pneumonia?
Yes.
So we don't want to lay them flat. If he can't protect his airway, we always want to or aim to position the unconscious client in semi-Fowler's, correct?
Okay.
So we can cross 3 out. What's next?
4.
She said no.
What do you guys think?
Mine probably oral temperature.
1,
No.
2.
The correct answer is 2. Okay. So what about 1 makes it wrong?
Keep the room temperature at 70 degrees Fahrenheit. Because the client is intubated, so we can't have anything in their mouth like over temperature.
Very good. Oh my gosh. That was really hard to catch and you caught it. Very good. We want to do like maybe like axillary for him, right?
Right.
But if his mouth is open, because technically, even if we kind of close his mouth a little, because he has the tube that's going to be sticking out of his mouth is going to be open. So that's not the most accurate place to check the temperature right now. And also, so write that down if you didn't know that. So when a patient is intubated, don't check the temperatures orally. Don't, and then also, what about keeping the temperature at 70 degrees Fahrenheit? What do you think?
It's too cool.
Too cold. 7 is not too cold.
We don't want him to shiver
Yeah, too cool.
because what's going to happen if he shivers? What can that do to his ICP?
It goes up.
It can increase it, right?
Yeah, it goes up.
And then the rationale says that don't do 4 because the draw sheet, if we're using that, it can brush up
It's,
against buttocks.
it's not even. It's not even.
Yeah,
Doesn't distribute evenly.
exactly. And it can lead to like friction against the skin and lead to skin breakdown. Okay.
So, Professor, what's the rationale for putting petroleum jelly? What rationale is there a way we could see the rationale for using the petroleum jelly?
Yeah,
Prevent sore mouth.
exactly. To prevent dryness. So,
Moisturize
yes,
Mm.
because
Yeah, we know. Is that not something? Okay.
to avoid
Is that what?
dryness.
Okay.
when someone's intubated, again, like their mouth is kind of open a little bit, even if
Start breaking.
yes. And so because their mouth is open most of the time, they're at high risk for dryness, dry lips, dry mouth. So we want to clean the mouth and get rid of bacteria. We want to keep the mouth moist. We want to keep the lips moist as well. Okay. So the nurse must clean the unconscious client's mouth carefully. Apply a coat of petroleum jelly and move the endotracheal tube to the opposite side daily to prevent dryness, crusting, inflammation. Okay, so that's that one. Did that answer your question, Miss Edna? Because I can reword it if needed.
Uh, no, I was just maybe the word petroleum jelly instead of a lip balm or something.
Yeah, like a
I was
back.
just I was thinking petroleum jelly. Yeah, that's
Yeah,
fine.
yeah, just to prevent dryness and crusting. Okay.
That's like A. That's like A and D.
Yes, yes. 94. The unconscious client is to be placed in a right side lying position. The nurse should intervene when observing a client in which of the following positions? This is a weird question.
I, I don't know. I'm leaning
Um,
towards
let's
4, but I don't know if it makes sense.
see. 3.
A left leg is supported on
Is
table
it
with
number
a
3?
knee flexed.
Yes,
Number 3?
yes,
3.
it's number 3. This one is so
3.
weird, but
It's
like
making make
it's
sense. The
saying that
left arm is
The
resting
elbow.
on a mattress
mhm,
with the elbow flexed. Mm.
it's saying that, but this question is
Mm.
so
It
weird.
doesn't make
One of those that you
sense.
say, okay, this is what it's
It
saying.
don't make sense though.
No, it's saying that they don't want the arm on the mattress without a pillow. So any joint, right? Like any bony prominence. So what are your bony prominences? Like the back of your neck, your shoulder blades, your buttocks, your knees, your heels. They don't want bony prominences on the mattress without a pillow because the bony prominences, they're more at risk for skin breakdown. So that's what they're saying. Um, that the client is not in proper body alignment um, because the elbow of the arm, um,
Touching the mattress.
yeah, it's touching the mattress. So that's the problem. So another weird question, but so just something to think about in questions. They don't want bony prominences not supported with a pillow. Okay, 95. Which of the following indicate that performing passive range of motion exercises on an unconscious client has been successful?
They are really critical thinking questions.
Mm-hmm.
Has been
But
maintained.
just everything about
Maintenance of joint mobility.
What is that word is?
uh,
Demineralization.
yeah, demineralization, yeah.
What that word mean?
Like to
Some
prevent the
long words.
bone, yeah, to prevent the breakdown of bone.
Mm.
So someone already said the correct answer. What do the rest of you think?
Number two?
Yeah.
Two.
It's not,
Three.
not two.
Not
Three.
two?
It's maintenance of one.
Four.
Is
The
it four?
yeah,
Maintain of joint?
answer is four.
Yes,
Very
four.
good. So remember, if we don't move the joints, this is what can happen. If we don't move the joints, and there's one, it's
Oh.
actually in the book, I'll show you. Hold on.
Contraction.
Yeah, contractions.
There will be atrophy.
Well, it's like the joints stiffen. If you don't move the joints, they stiffen.
It's like wasting.
Yeah. Yeah. Yeah.
Right here. Mhm.
On page 47 of the study guide. So these are contractures. So like if you try to, like you see how first of all, you see how his knee is on the mattress without a pillow? That's a problem. The heels, I mean, like this is a disaster, like a disaster. Um, we would really need to do a lot this guy. But
Poor
so
guy.
I know if you tried to straighten his leg out, it would probably be like almost impossible because
Break him. Break the bones.
right,
Stiff.
yes, and the joints are very stiff. So that is we prevent this from happening because once it happens, you can't really reverse it. It'd be very hard to, but you can prevent it. Oh my gosh, like you just see his whole femur right here.
Is this an actual human being or is a skeleton?
It's a
No, it's a human being.
Oh
human.
my
We
God.
had one facility that just passed about 2 weeks ago.
Oh my God.
So
It's,
this is what we call cachexia.
Oh.
Yeah, it's a
that
very
one that one was just like this with a very big wound.
Ah.
yeah. So this is cachexia. It's a very emaciated appearance. Okay. So the correct answer for 95 is 4. So we have to perform passive range of motion exercises so that we can maintain joint mobility and prevent contractures. And contractures are the shortening of a joint. Okay. They become stiff. 96, when the nurse performs oral hygiene for an unconscious client, which nursing intervention is the priority?
Keep a suction machine available.
One.
One.
Or excellent. So remember, maintaining a patent airway is your number one priority. So you have to have that suction equipment available to remove secretions if needed. Okay. 96. So two more questions. So 97. The nurse observes that the right eye of an unconscious client does not close completely. Which nursing intervention is most appropriate?
Two.
Beautiful. Yes. Okay. So when the blink or the corneal reflex is absent, corneal reflex or blink reflex is absent, or the eyes do not close completely, the cornea may become dry and irritated. Corneal abrasion may occur. Taping the eye closed will prevent injury. Having the client wear eyeglasses, it won't really protect the cornea. It's still open and exposed. Cleaning the eyelids will not protect the cornea from dryness or irritation. Artificial tears installed once per shift are not enough in preventing dryness. It'll probably need to be like every 4 or 6 hours or something, but still, if the eyes cannot shut on their own, we have to lightly tape it because to prevent corneal scratching and abrasion. Okay, last question. Which sign is this is a good one. Which sign is an early indicator of hypoxia in the unconscious client? Now, this is a good question.
Three.
Very good. Very good. Remember, guys, for your exit, for your NCLEX, restlessness is always a problem. That is a trigger word. You should be like, oh my gosh, something's wrong. If a question says the patient is restless, I want you to write this down. If the question says the patient is restless, you have to check two things, the oxygen saturation and the blood sugar. One of them
Hi.
is probably
Hi.
normal, okay?
We're gonna see what happens next week.
Which one would you want to check first? Would you want to check the O2 saturation or the blood sugar?
O2.
Two.
The O2, very good.
O2.
Now you're thinking that's part of the ABCs, right?
I'm sorry, Miss Alexandra. Can you repeat for me, please?
Sure. So when a question says the patient is restless, there's two things you should check. You should check O2 saturation and blood sugar, but you want to check O2 saturation first because that's part of the ABC. Okay. So what would restlessness look like? Would it look like they're uneasy?
Shortness of breath, kind of.
Mhm. So restlessness, would they be just laying still in bed peacefully, or could they be maybe like moving around nervously?
Around nervous, uneasy.
Nervous.
Would another word to say it maybe be like anxious? Yeah,
Yeah.
anxious, um, uneasiness, apprehensiveness. Okay, these are common words you're going to see on your exit or NCLEX. Restless, anxious, uneasy, apprehensive. All of those equal check O2 saturation. If that's normal, then you check the blood sugar. Okay. Why didn't you choose one?
Because of perfusion issue.
What's the key word in the question?
You're talking about 98?
98. Yeah. What's the key
You
word?
say hypoxia. Hypoxia, there is no oxygen.
Well,
Early
what
indication.
early?
Early indicator.
Really, very good. So what is cyanosis?
Like
That
blue
is
color.
a bluish coloration.
Like turning blue.
Discoloration.
Right. Because of hypoxia, right?
Yeah, because of hemoglobin.
But is it an early indicator or a late indicator?
Late.
Late. So that's why you didn't choose that one, right?
What is cyanosis again, Miss Alexandra?
Sure. It's when the tissues turn like a bluish tinge, a bluish pigment.
No oxygen.
Right.
Yeah, the hemoglobin,
Mhm.
you know,
But that's a late indicator of hypoxia. So an early
it
indicator
will be hypotension.
an early
No.
indicator would be restlessness.
Restlessness.
So,
Number 3.
well, it's what we just said anyway. So,
Mhm.
yeah.
Hypotension and decreased respirations, those would both be late. Mhm. Okay. So, all right, guys. So for homework, please make sure that you read the rest of Module 4. And then we'll be back next Wednesday. I'll message you if class is going to start at 9 or 9:30. I had to teach another class for my other job. So that's why I had to push class to 9:30. But it
So
was Always, it's a pleasure. I'll send the recording in the morning once it finishes loading, and I'll see you back here Wednesday. I'll message you, so it's either 9 or 9:30. Thank you, and have a blessed evening.
Thanks for your
you.
time.
Thank you, Miss
you.
Alexandra.
My
Thank you.
Thank you.
Have a blessed night as well.
Good night.
See you
Good night.
next
Good
week.
night, everybody.
Good night.